So I think we are ready to start, Kate.
Great, sorry, thanks.
Okay, perfect. So thank you everyone to be here, and we will start with an introduction from our PSI Asia Pacific Regional Secretary, Kate Lapin, who will introduce the meeting and why this is an important opportunity. Please, Kate, go ahead.
Great, thank you, Susanna. And welcome everybody. Thanks for making the time for this meeting, which I think is a really important process for us to engage. This is the first meeting that PSI is having amongst the regions to do with sorry?
That was interpretation, I'll just do that.
Okay. This is the first meeting that PSI is having in relation to this general survey that the ILO is conducting around the Nurses Convention and the Domestic Workers Convention and their recommendations. So in some ways, this meeting will also help us to establish some of the key messages. It'll also help us to review the work that we've started to do on the convention and to plan the next steps in the process of elaborating and responding to the survey, but also building a campaign so that we see this survey as an opportunity really to campaign around the rights of workers in the health and care sectors. PSI has engaged a consultant who's going to help us through this process, and he will be speaking to you today about the background, and both Susanna, Banani and Carol will all be taking notes on some of the responses you provide, as well as following up with all of you. Just a little bit about the process before Carol is going to tell you more about the instruments, but the review that the ILO is undertaking was actually planned prior to COVID of these conventions, and it's been delayed by a year, not just because obviously the ILC, the International Labour Conference, was delayed last year because of the pandemic, but also because it was obvious that the conditions that workers were facing during the pandemic were really important to record. And so the whole process will now include the original review, as well as be an opportunity to record the issues around labour rights that nursing and care workers have faced in the last year. So it was very timely that this was on the ILO's agenda. Now I'm going to share a screen as we start. Screen up. And I just really want to emphasise that, as I said, this is the first of the meetings, and this will not be the last opportunity. Today, it's really to give you the background and the key questions, start to get some input from you, but it won't be the last. And in the next part of this process, we want you to be speaking to your sub-regional secretaries in your regions to look at whether you will be putting in a national response to the survey, and what plans you might have to use this survey in your own organising and campaigning work. So let me start off a bit with why we think this is such an important opportunity for PSI affiliates. First of all, I suspect not many, actually, even within the health sector, not many unions have really drawn on the Nursing Convention in its 44 years. It's very, has a poor ratification rate, and we maybe have underutilised the fact that it exists. And it's a it's a dated convention. It reflects some of the principles of when it was developed. And I think as we go through the process, it'll be part of our review to work out what we want to do with this convention. Should we be lobbying for more ratification? Should we be lobbying for a new instrument or updated instrument? And that is part of the questions we want to put to you today. So first of all, it's as I said, it's 44 years old. So this is a really important first process to review the convention. We need to also highlight that although it's got a low ratification, the process of the General Survey is not only for countries that have ratified it. The General Survey is for all members of the ILO. And so this has already been sent to every government. In the time, obviously, in the last 44 years, things have progressed, and the ILO itself has also developed further policies in relation to health. In the last few years, particularly, the ILO has been doing work on the labour rights issues within the health sector. And obviously with the pandemic, that has even further magnified some of those issues and drawn attention to the issues of nurses and other health workers. And the whole process is expected to highlight some of those issues that PSI and our affiliates have been campaigning around and seeking to expose, whether they be issues around healthcare and the failures in public healthcare funding, the failures to properly staff both public systems and within privatised systems, the inequalities that exist within health systems around the world, and what would it take really to have decent work for health workers, including for those that might not be categorised at the national level as nurses or within the current scope of the convention. So we really do see it as an opportunity to draw attention to some of those key issues, the importance, obviously, of public health, the connection between good working conditions, decent work, public funding, and public health outcomes. Also to draw attention to the dangers of privatisation, the concerns we have about the limits on industrial action or the limits on collective bargaining in some countries for health workers, the gender pay gap in healthcare, and I think that's a key issue that you almost within the convention there is a tone of this being care work that therefore is different than other forms of work. So the importance of addressing that and the mechanisms that unions have utilised to elevate healthcare workers' salary and conditions in some countries, and the fact that in many countries it remains an enormous gap. Some emerging work that we think we can tie into this process is the idea of care as a human right. And that's really been developing in the last year with the pandemic. And whilst it's not part of the convention, we see it as a potential to connect the review of the convention and this emerging idea of care as a human right. And of course, I think it's a great opportunity to bring unions together, the review, and it'll give us better opportunity to collect information about the reality for health workers in different countries, but also to unify unions around common messages that, you know, whether we be in a developing country or a wealthy country, there are some commonalities. So we really want to not just see this as an instrumental process or as just a survey that we fill in, but as a longer term campaign. So while we have a deadline, and the immediate deadline is to submit these surveys, that will then lead to, in another year, that will lead to a report at the ILC that will lead to discussions amongst governments, employers and workers' representatives that could then lead to a number of recommendations, including new instruments or actions, it could lead to campaigns for ratification in a number of countries or changes to conditions. And it should also lead to better understanding by unions of the existing international standards for nursing and care workers. So that is the overall sort of, I guess, introduction and purpose for the review. There is also there are a number of opportunities for us to put in material to the ILO. So PSI will be submitting an overall response, country level responses, but we may also look at thematic responses if there's interest from affiliates. So, for example, doing one across countries that's specific on community health workers and the way that this instrument could apply to them and the challenges they face. Another might be something like aged care workers, or perhaps across care, disability and aged care, those that fall out of, that are, you know, falling out of the public hospital system. And we're interested in your feedback on that. So we haven't made all those decisions yet. Today's part of getting your feedback. So with that, I'm going to hand over to Carol. He's, as I said, we've engaged Carol Florick to help us with this process. He's a very experienced unionist and health researcher. So that's the two areas of expertise that he has, is health and care work within unions. And he's been part of processes to engage international institutions and the standard setting around care. So Carol, I'll hand over to you to present the contents of these instruments.
Hello, everyone. So I'll talk for about 10 minutes and I'll cover what's in a bit of a summary of what's in the briefing paper that that should have been sent to you all. So it's an overview of the Nursing Personnel Convention and the Nursing Personnel Recommendation. And if I could just share my screen, that might just make it a bit easier for me. Yeah, great. So I'll just put my screen up. Hopefully you can all see that now. Okay.
Yes.
So the first, sorry, I'm just filling here. The first thing to note about the two instruments, there's a convention, which is a legally binding instrument for countries that have ratified it. And then there's also a recommendation that accompanies the convention. That recommendation is not legally binding, but is very much sort of attached to the convention. The thing to note here is that the convention itself is quite slim. It only has 7 substantial articles in it. And to summarize it, if I was to summarize it in a sentence, I would say that it essentially obliges governments to recognize the work of nursing personnel, to define nursing as a distinct occupational group incorporated into health policy, and to recognize their right to representation and to collectively bargain. The recommendation, however, is much more substantial and detailed. It covers issues like integration of nurses with health policy, the classification structure, training and education, organization of working time and schedules, occupational health and safety and compensation for special risks, social dialogue and collective bargaining, and issues of international migration. I'm going to go through some of these issues that are both in the convention and the recommendation, and sort of point out where some of these gaps are. So the first thing to note is that there is a strong focus in these instruments on integrating nursing personnel into general healthcare policy. This is meant to occur through policy measures, including education and training, working conditions, career prospects, remuneration, and so on. There are several references to how these policies are needed to attract and retain the nursing workforce to ensure health needs are met. Now, I think that this is quite interesting. If we reflect that this convention dates to 1977, we can see how long and persistent these issues of the problem of workforce shortages has been. Importantly, nursing personnel or their representatives are also meant to be included at all levels of decision making, including in decisions around national healthcare policy. The definition of nursing personnel is a very important aspect of the convention. The definition put forward is universal in principle. So it is all nursing personnel, wherever they work, including all categories of persons providing nursing care and nursing services. The recommendation further proposes a three-tiered classification structure. This is meant to consist of professional nurses, auxiliary nurses, and nursing aides. In theory, therefore, the definition of nursing personnel within the convention should cover everyone providing nursing services across the entire health sector. So not just limited to professional nurses in hospitals, but to nursing homes, to community-based health workers, everyone providing nursing services, whether it's in the public sector or the private sector. However, we know that in practice, this is often not the case. So the convention, unfortunately, does not define the specific sectors that it covers. Also, the convention allows there's a provision in there for excluding nursing personnel who are performing work in a voluntary capacity. And we'll come back to this point at the end. So education, training, and professional practice. I'll cover this very quickly. The convention establishes the need to limit the practice of nursing to workers with required education and training. The recommendation proposes 2 tiers of education and training, an advanced level equivalent to university level education and a less advanced, which is equivalent to sort of technical training. There are a number of interesting things recommended relevant to how differently qualified groups of workers should be employed. So one of those things is limiting practice to authorized persons. Another is not using workers in lower classifications as substitutes, except through agreement or in cases of emergency. And in those cases, unions should be consulted on the conditions of such exemptions. Not using students to meet normal staffing needs. And finally, around paid education leave, providing opportunities for career advancement and promotion for workers who undertake continuing education. There is a big gap between what is in the convention itself and what is in the recommendation in regards to working conditions. So the convention only commits to ensuring, only obliges governments to commit to ensuring nursing personnel enjoy at least equivalent conditions to other workers, and it establishes a preference for determining this through negotiation. The recommendation, however, goes into quite a lot of detail about what the organization of working time and schedules should look like, what the limitations should be on shift work and on-call duty, around rest time, various kinds of leave, and compensation for particularly arduous and unpleasant conditions. It also establishes a remuneration, establishes that remuneration should be established by collective bargaining. So I'll talk briefly through each of these points. So in regards to working time, they're quite detailed, the provisions that are in the recommendation. Overtime should be the exception rather than the rule. That's a key principle in there. There should be as little recourse to work in overtime, in on-call duty, and at inconvenient hours as possible. There should be compensation for overtime. Inconvenient hours should also be compensated with higher pay. And planning really needs to factor in staff leave and absences, so not to overburden staff when workers are sick or absent. The normal working week should be reduced to a maximum of 40 hours without a loss of pay for workers. Normal hours should be set at 8 hours per day, and where there's overtime, the day in total should not exceed 12 hours. There is a possibility there for various exemptions to this that could be established for specific laws or for collective agreements, for example. And also in cases of special emergency, there may be temporary exemptions. However, the conditions for emergency exemptions should be taken in agreement with unions. In regard to rest time, it should be no less than an uninterrupted 36 hours. There should be reasonable meal breaks and rest breaks, which should be established in agreement with unions. Workers should also be entitled to generous annual leave, sick leave, and maternity leave. So on health and safety, we all know that health and safety is an absolutely critical issue for health workers. In the last few months, the ILO has produced reports that note that health workers are among the most affected occupations by COVID-19. The ILO also recognizes that the health sector is among the most hazardous sectors for health and safety. Those hazards include not just infectious diseases, but things like musculoskeletal diseases, mental burnout, physical violence, and harassment. The convention itself, however, only contains one provision relevant to occupational health and safety, and that is that it obliges governments, if necessary, endeavour to improve existing occupational health and safety laws and regulations. It does not, however, define this necessity or the conditions for this necessity or specify any particular obligations for health and safety. The recommendation, meanwhile, is a bit more specific. It deals with the need for occupational health and it deals with the need for occupational health services, the need to carry out risk assessments to prevent risks and to compensate for them where appropriate. It states that illnesses contracted as a result of work should be compensated as an occupational disease. Very importantly, and relevant to the current situation with the pandemic, I think, is the point that in addition to a general definition of occupational diseases, there should be a presumption of occupational origin in respect to certain diseases, and that diseases that are added to that list should be reviewed and revised regularly. Finally, the recommendation also contains specific reference to protecting pregnant women and parents of young children from exposure to risks, and these include infectious diseases and mitigating such risks by, for example, transferring workers to safer roles. Related to these provisions on occupational health and safety, there are a number of important points around what is in the convention called particularly arduous and unpleasant conditions. There should be financial compensation. This can also come in the form of reduced working hours and longer rests without loss of pay. Unions should be consulted about what kind of conditions are considered particularly arduous and unpleasant. And workers should also be compensated for being exposed to special risks. Specifically, this includes exposure to radiation, to anesthetic substances, and to infectious diseases, as well as to mental illness. Such risks should be eliminated or minimized as far as possible. And this should be done in collaboration with workers and unions. On remuneration, as I mentioned earlier, there's a principle for establishing it through collective bargaining as a preference. The level of remuneration should reflect a number of different things. The value of the work, it should be commensurate with comparable professions that require similar qualifications. It should reflect skill and responsibility and take into account the difficult nature of the work. It should be comparable across different sectors that employ nursing personnel. And finally, it should be set at a level that is sufficient to attract and retain the workers that are needed. So there's a sort of like number of different principles there that are defined that should determine remuneration, but also establishing a principle that this should be done for collective bargaining. Okay. Yeah, so there's two aspects of this convention, however, and the recommendations that are unfortunately somewhat problematic. And this is how it deals with the issues of job security and so-called special employment arrangements. So we have to remember that this was adopted in 1977, and current policy of the ILO recognizes the problems of precarious employment. Recent reports note that decent work deficits are closely connected with privatization and outsourcing trends and the erosion of permanent public health jobs. However, the recommendation is deficient on this point. It conflates, first of all, part-time work with temporary jobs, and it frames it in a positive way, so that such arrangements should be introduced to make the most effective use of available nursing personnel and to prevent withdrawal from the profession. The convention also contains the provision for special rules in relation to volunteer nursing labour who can be exempted from all parts of the convention other than the articles that relate to education, training, and occupational health and safety. It does, however, state that decisions on volunteer nurses should be made after consultation with employers and unions. Yeah, so that brings us to the end of the sort of overview I wanted to give on what are the kind of key aspects and provisions of the convention. So I'll just stop there, and if anyone has any questions, please let us know.
Thank you very much, Carol. There was actually a question that was put in the chat box by Andrea from about the difference that you make between nursing and care work. But maybe if Andrea would like to take the floor and ask the question or elaborate on it.
Sure.
Yes.
Kia ora, everyone. Hello, welcome from New Zealand. I work for the PSA, the Public Service Association, in the policy team. And since the convention uses the term nursing all the time, and you elaborated that it includes care workers, I was wondering if there is a definition in the convention or anywhere else that distinguishes nursing from caring. Is there a difference in terms of the convention? Because for us in New Zealand, it would be more common to use care work or healthcare, rather than nursing. Nurses are just that specific occupation that deals with specific aspects of the healthcare workforce. Thank you.
Yeah, so it's not defined. That's part of the problem, and part of what I think is useful to this kind of discussion, to sort of define what it is that what is covered in this terminology. So the terminology is nursing services. So nursing personnel are people who provide nursing services. So yeah, there's definitely in the general survey, as it sort of asks these questions of governments, it does sort of include questions about care and the care economy, and it does extend into nursing homes and all parts of the care sector.
Thanks, Carol. Kate, did you want to add any point on this?
Yeah, I mean, it's important to note that the whole survey is, it's framed as the care economy. PSI doesn't like to use that term because we think it, financializes care, but it includes the review of the domestic convention, and that domestic workers convention, I think it's, obviously targeting people that work within home, but also we don't think that really covers home health care or aged care or workers that are employed by an external agent, see whereas the Domestic Workers Convention is really designed for people who are employed by the residents of a home. But part of this process is for us to decide whether we think that there needs to be a change to the way that workers who are delivering a form of healthcare whether they should be included in this instrument or in a future instrument, particularly those who are in areas like aged care, disability care, who have a responsibility often to deliver forms, part of the of a health, system, but aren't qualified nursing personnel or, who don't have a nursing qualification. And, part of this process is actually to look at whether we think they should be registered and, whether that should be part of either the existing 3 tiers or a new 4th tier or something else. So we would like to get through the process to get affiliates' feedback.
Thanks, both of you. And maybe as it might also clarify for Andrea, the recommendation does mention professional nurses, auxiliary nurses, and nursing aides. And the professional nurses being defined as having education and training for highly complex functions, auxiliary nurses for less complex functions, and nursing aides having education or on-the-job training that help them take some tasks. So there is a certain gradation there that might go beyond what the usual understanding of what a nurse is. Are there any other questions?
I think Mark has put a comment in there about the levels, which does get to one of the questions that we want to get feedback on as we go through the questions, is really, this is an essential issue, which is how do we respond to the existing categorization.
So maybe we can go ahead with that. Kate, you will continue with the presentation.
Okay. All right, so now what we want to do is go through some of the questions in the survey. Well, we're not going to go through all the questions in the survey. What we really want to do is focus a little bit in on sets of questions that need affiliates' comments, but also what some of the key messages that we would like to see in each of the national responses are. And get some of your feedback, and then we will try and discuss whether there are other key messages and come back to you about the national process. Carol, maybe you would like to present the first part here, which is really about how the instrument is structured, as the survey is structured.
Okay. Yeah. So one of the things to note about this report form for the general survey, there are 56 different questions here, and they're sort of broken up into a number of sort of subcategories, subheadings. The first part kind of deals with the Nursing Personnel Convention and Recommendation. The second part deals with Domestic Workers Convention and Recommendation. And then there are some sort of general parts. So really we're talking about the first sort of bits there, and then the last bits. One of the things about the way that this form is structured, sorry, I might have just frozen there for a moment. One of the things about how the form is structured is that it is quite legalistic, it's quite bureaucratic, and it can be a bit intimidating and hard to sort of really understand what the questions are asking. So the questions are written for governments, that they're framed for governments with policy departments and so on. And I think that in terms of how to approach this, the kind of guidance that we can provide, and the ITUC has already provided some guidance on this kind of question by question. We can really break this down into sort of key issues or key questions that we can ask, and kind of feedback on those questions in a way that's a lot more logical and thematic, rather than sort of trying to tackle the bureaucraties of these questions. So that's kind of how I would sort of suggest we approach this. Yeah, so I would hand back to Kate now to go through some of the questions that you just there and key messages.
Okay. Thanks, Carol. Yeah, so, oops, somehow going backwards. All right, so here we are. Then the first part, I think, of the questions that we really want to get your feedback on has already started to be discussed. So as Carol mentioned, really there's a set of questions, and we're not going to go through every question in this webinar, but one of the key questions is around this structuring of the 3 levels, the 3 tiers that are set out in the recommendation of professional nurses, auxiliary nurses, and nursing aides, and that Susanna just mentioned. Where Carol's sort of looked at it and created a bit of a matrix here for us to think about how these categories may fall within a range of work that could be considered nursing or healthcare, from the formal to, in a number of countries they could all be formal, but in some countries even some of those workers could fall into within the informal sector. So what we really need to work out is whether this is sufficient, or do we need additional tiers? The last category of nursing aides, I mean, the language of it, for example, wouldn't, I think, normally be applied to a worker who might be in aged care. I mean, they're taking the primary role. There might not be a nurse who actually, apart from in management, might not actually see a nurse. So nursing aide might not be appropriate, although I guess if we needed to, we could make an argument that they could fall under this convention if we were trying to expand labour rights. The second part of this question is, Carol also mentioned earlier, that there is provision made for volunteer work, and we are particularly concerned about that because of the work we've been doing with community health workers who've been classified as voluntary workers, and we wouldn't want that to be retained, I think, to give governments the authority to designate a whole category of the public health workforce as voluntary. But we also wonder whether affiliates see any problems with advocating for that to be removed. Yeah, so these are really core questions, I think, around whether we want to see these 3 categories retained, and whether we should make a particularly, vocal objection to the volunteer category. What we're going to do, I think, as we run through these is actually take some of, take it slide by slide, take some of your feedback on whether we think, on the key questions that we're highlighting, and then we'll go to the next part of the question. But maybe Mark, because you've put in a response to this, you might like to speak to it.
Yeah, hi Kate, thank you. I'm very happy to talk to it. In Australia, our classification system, of course, we are governed through a health regulation, which puts us, there are 2 levels of regulation, which is a registered nurse and an enrolled nurse, and then there is a midwife, which is the 3rd or a different qualification. Level 2 a registered nurse, but they are particularly a midwife. So in Australia, you don't have to be a nurse to be a midwife, but you have to have the appropriate qualifications and educations to be registered as a midwife. We have then what we call the unregulated healthcare worker, which we've been pushing for through a number of professional and industrial forums to be registered or under the health law, which there are some leeways being made around that. And they used to be called nursing aides. They tend to be now called assistants in nursing or healthcare workers, personal care attendants, personal care workers. And they have to, most of them have to have a particular type of certificate 3 qualification to go in there, but not always. Registered nurses are certainly trained through the university sector, and that is the baseline qualification for registration. An enrolled nurse is more your what would have been a part of a nursing aid in the past, where they were a tertiary qualified person, and they're actually trained through the TAFE. So like a technical college or a college that has been approved to provide that program, which can be an NGO.
Mm-hmm.
Also the languages. They talk about professional nurse. While we believe nurses are professional, registered and enrolled nurses are professional nurses. And the unregulated one isn't so much, it's an unregulated worker.
Mm.
And then in the classifications, there are many from, and it varies across the whole states in Australia. We might have a different, slightly different models, but basically there are advanced nurses who can be clinical nurse consultants, or in some states they're clinical nurse specialists or just clinical nurses. And then there are registered nurses, whatever 1 to 8 or 1 to 9, whatever your structure has and so forth, and then enrolled nurses underneath that. And at this stage, directors of nursing are also of a nursing background. When you get to the aged care sector, the healthcare facility doesn't always have to be a nurse, but there has to be some sort of senior nurse within the, and this varies across the state as well, the country, with various different rules around that.
Mm. And I've noticed that with the Aged Care Royal Commission, there's recommendations around moving towards a more some level of recognition of the skills and qualifications required.
Yeah, the unregulated worker, and certainly they were talking about that in that pushing also to get them regulated in a particular way. There is a code of conduct, but that's not sufficient.
Mm. Yeah, so I think that's really useful feedback. I mean, that's exactly what I think our concerns are here, that nursing aid, the language of it doesn't cover the extent or the breadth of roles that there are. Unregulated worker, health worker is a good, it's useful to note, I think, for us, because that would be consistent in a number of countries. And
some policies or our position statements on all of that, if that would be useful.
Yeah, that would be helpful, I think. Thank you. Yeah. Are there any other feedback on this from other countries similar? I imagine that some of the registration processes are similar, but particularly around this last category, unregulated, isn't it? Or workers that have actually fallen this matrix.
Kate, it's Rob Bonner here.
Hi, Rob.
I think that one of the whilst unregulated health worker covers things at the moment, it wouldn't work in the longer term in areas like disability and aged care if the Royal Commission's recommendations are accepted and those people are then licensed in some way. So that I think that we've got to be a bit careful about adopting a title for this policy that might vary from country to country or from time to time in relation to regulation. I think that the issue for us is the different scope of practice that exists for a sort of professional registered nurse in terms of assessment, treatment and delegation. Enrolled nurses who are required to work under supervision but have their own scope of practice, and then unregulated workers who work almost entirely currently under systems of delegation and levels of training that sit with that. So I just think we just got to be a bit careful, given certainly in Australia, the current debates around and almost definite regulation in some way of personal care workers, assistants in nursing and aged care by the end of this year.
Yeah, I don't think we would be calling for the term unregulated worker to be included, but in our submissions, we might say there are a group of workers who are currently unregulated in a number of countries, but should still clearly be covered by international instruments that protect labour rights. And nursing aid doesn't adequately cover perhaps that.
And the common feature of those might be that they are performing under supervision aspects of basic nursing care, as opposed to the more complex and advanced stuff.
Exactly.
Yeah.
I think that's a helpful way to think about it. And in some countries, these are informal. You know, this is the concern we're trying to raise, is that all workers should be formalised. But at the moment, that group of workers is often informal, can be engaged through, you know, without any, well, not just regulations, but could be engaged within an informal. So, I mean, I think this is a really helpful, these inputs are helpful. If anybody has any comments here, I feel like this is probably needs us to put together a briefing paper specifically on this issue, or a short, you know, briefer specifically, and get affiliate feedback, because as you point out, it's different around the world. Has anybody else got comments? I note also the comment on community health workers, which I'll come to in a moment. Nope. So the next one, which the key question here really is around the fact that the existing recommendation includes provisions for volunteers, although it says that it should be done in, it should be negotiated with representatives of workers' unions. That's obviously not been done, or as far as I'm aware, in terms of having a whole workforce that's volunteer. But we want, there may be reasons, I think they're pretty marginal. I mean, obviously there are some times where there are volunteers to do with Red Cross and so forth. But the important thing for us is that other international instruments rarely would address, you know, have a provision for volunteer work. And so I wanted to get input from others on whether a position that this should be removed would be a problem for any affiliates. No. I mean, you can also come back to us if you need to consult with others within the union, but I think it's an important position that we need to agree on.
Kate, it's Judith. Just on that volunteer work, obviously we don't have that here in Australia. Most of our, I mean, in aged care, I guess you can have maybe families doing a little bit, but it's not a actual part of work like it is in other countries. And I'm just not, I think what it says there, you know, who negotiated those rules, and should there be any provisions allowable for volunteer work? I mean, wouldn't our, we would be coming from a perspective that no, work is work, and you know, there shouldn't be volunteers. Now I know that poses massive issues for some other countries that do have a lot of volunteer work. But if we're trying to update a policy, my view would be that there shouldn't be provisions for volunteer work. Just putting it in there says that it's okay to do. And you know, on the other hand, you'd have to be careful, because if you take it out, people might still do it anyway. Well, it depends, I guess, who signs up to the agreement. But I just think as unions, we shouldn't be negotiating for volunteers.
I just follow up
Yeah.
on that. Andrea.
Yeah,
you
I mean,
sorry, you
go
go,
ahead,
Kate.
Freya.
Okay.
No, you go.
Cool, thank you. Just following up from what Judith mentioned, in New Zealand we have it's not a defined category, but we have paid family carers, you know, and they don't have any qualifications or registration or anything, but they get paid for the care work they do for a family member or other relative. And you know, we are currently in contact with an NGO that is supporting family carers. And we see it as an organizing opportunity as well to ensure, for example, pay equity rates for these family carers, who obviously most of the time are women. And would we want a type of worker like paid family carers included in such a convention? Although I understand it's not relevant for all countries, but how do we deal with these specific categories that might exist only in, you know, certain jurisdictions? Are they relevant? Are they also maybe an opportunity for union growth? You know, take it a bit wider, I guess, than just the convention, but would it be beneficial for unions?
Kate, there was also a comment.
Well, I mean,
in the
I think
chat
that's
box.
part. Sorry, Susanna, go ahead.
Sorry, I just wanted to highlight there was also a comment on the chat box about if community health workers could be part of the survey since they're working for community health. So maybe that links also in question in terms of those specific categories of workers.
Right, yeah. I mean, I think we should be able to, in the survey at least, cover all forms of health and care. And that can help us bring together the international experiences to be presented, and, you know, hopefully also good practice, and that can then lead to these organising opportunities. The care, in some cases, there will be a crossover between the questions for the Domestic Workers Convention, which is a lot newer. The Domestic Workers Convention, you know, is less than a decade old. I think it's 2011, and so that has other provisions in it. So that I don't think, I think if there's examples in some countries, we don't only have to be restricted to those that are in every country in order to provide feedback and illustrations from unions, particularly if that illustration can demonstrate the value of, you know, unionising those workers or the value of public health investment. So we definitely welcome those. Just on community health workers, so Judith's point is that what we mean by community health worker varies from country to country. In some countries, they're qualified nurses that would be providing primary health care or other forms of care, but not in a hospital or clinical setting. In the community health workers we're working with in South Asia are delivering parts of the the primary health system. I mean, they're They're workers who are delivering vaccines. In some cases, they're delivering maternal and child health, like a maternal and child health care nurse might in some countries, or what we might have called a mothercraft nurse, those sorts of things. So there, there's some areas are similar, some are very different. I mean, they're also walking into remote and rural areas to do some of this work, sometimes supervised, sometimes unsupervised. So partly that's why we thought we should have a specific submission for those workers, because it is different and couldn't just use community health work and assume that it's the same across the world. So if we make a submission that makes it clear those workers don't want to see their work regarded as volunteer work, and that those unions did not agree to that being categorised as volunteer, which the current recommendation suggests. I think that can be a powerful way of presenting it, and not necessarily in the PSI's, other submission having to define differently what community health work means around the world. Okay, I think I'll move on to the next question. This is a critical one, and as I said, I think we need to elaborate a bit further and get affiliates' feedback and around the world. Okay, so part of this first set of questions is also an opportunity an opportunity there for us to talk about the health system, and in what conditions can workers enjoy decent work, but what undermines decent work, as well as the need for a national health policy. I think one of the unique things about this convention is it recognises the need for a government to have a national health policy that meets both its public health needs, optimal health needs, as well as the right to decent work for health workers. And so unlike some of the other conventions, it's dealing with a public service issue in addition to labour. And so this does give us an opportunity to try and elaborate on what we think be an obligation of government to invest in public health, and what the I guess barriers to both public health and decent work are. And so through doing this, there's a few comparative statistics that would be good for us to put together in collaboration with each country, and perhaps drawing on the great database of material that the World Health Organization puts together, but try and come to some common indicators. So these are the kind of areas that aren't not clear in the survey, but that we think should go in. So things like what percentage of government expenditure is on health, what percentage of the total expenditure of health is private and what is public, or sometimes that's out of pocket spending. And then from there we would look into other areas around the specific targets to improve the quality of health, but also of this is the language of the survey, the quantity and quality of nursing care. So that would be the ratios, the nurse to population ratios, as well as the nurse to patient ratios. So these are two different types of indicators that can be used, and we would obviously want to see more countries adopt particularly the nurse to patient ratio. While the nurse to population ratio is a global indicator, it really doesn't say that much about the working conditions of those nurses, depending on the health of the population. So we'd like to really try and collect those ratios, and that's obviously in some countries that's very different between the public and the private. So we would also want to look at that, public-private, and of course you also get state-based differences. So we'll be looking at the maximum and minimum in a country like India, where there's vast variations in the states. So this is something that I think will help to provide a global picture of the huge variation, but also help for campaigns for increased public health. Another key area there is around the recognition for the right to care. I mentioned earlier that we want to start building campaigns around. And the global shortage of nurses. So that's obviously some material that we've already been part with the World Health Organization, trying to work on how should governments address this global shortage. And then we also want to hear from you around what are the other key demands that unions are raising around reform of health, so that it can meet the optimal public health system as well as decent work. Yeah, so are there any comments here? Some of you may remember that at the last Congress, the PSI Congress, there was a debate over this particular issue of ratios, and that the resolution was adopted that PSI would take a position to support ratios. So this is a really good opportunity to put that resolution into practice and do a bit more work on what the global standards on ratios are. So we're interested in the feedback from affiliates. I know it won't be always easy to get the data.
Kate, it's Judith. I've got a couple of comments. The first, the nurse to population ratios, I worry, is that language currently in the either the regulation or the, what do you call it, the other one?
Convention. No, neither of them work. Neither of them use ratios at all, not nurse to patient nor population, but the World Health Organization collects, the World Health Organization collects the data on the population to nurse ratio.
And I understand that, but I think if we can't include them both, because basically that would give governments opt out. They can say, well, we have X number of nurses for our population, therefore we don't need to do nurse to patient ratios. But I think there is so much research now out there globally that talks about the advantages of appropriate nurse to patient ratios, that it would be really hard to go past that. And the debate at Congress really was from the people that already have really good staffing, and they were worried that we were going to bring their levels down, when in actual fact what we'd like to do is get everybody's levels up to what they've got. But we're coming from a pretty low bar. I think we'd have to recognise that given that there are only still a few places in the world that have true nurse to patient ratios, and that's Queensland and Victoria and California. All of us have versions of, certainly we have a thing that can be converted to a ratio, but because that happens, it also can be rorted. South Australia, Rob, I'm talking for you, but I mean, you have a few good things down there, but you don't have across the board nurse to patient ratios. And the United States has really struggled, and Canada's just getting on that page now, because governments by and large are philosophically opposed, because it dictates to that, it tells them what they have to do and takes away their capacity to rationalise funding and all that sort of thing. But if we just were to concentrate on the research that says nurse to patient ratio saves lives, and but it's just that thing about it costs money certainly to implement it, but at the end of the day it's whether governments are really interested in providing optimum healthcare as opposed to adequate healthcare. I remember when we were trying to negotiate these in our own industrial negotiations, the boss of the health department at that time just said to me, Judith, you can't have optimum. You can aim for optimum, but you can't have optimum. And I said, what a load of bollocks. But so I'm thinking that if it's truly about patient care and good quality public health services, then we do have to argue for nurse to patient ratios as and they have to be mandated, and like we have minimums, and of course the employers use that as the maximum. They'll all, and Victoria, who's had them since 2000, still has to bargain every time around the employer wanting to lower them and all that sort of thing. So it won't necessarily totally fix the situation, but it'll go a massive way towards quality health services. And just in this last month, we're about to go into award negotiations again. And, you know, they just tell us they haven't got the money to do it. They don't want to do it. It's a neoliberal government. So but our members are telling us when we go, we've just been out and done a face-to-face walk around across the health facilities to ask the members on the ground what they think. And they are still saying that ratios is the way to go. That's what they're willing to fight for. And it comes above pay and other things. So I think if we were to ask nurses around the world, and we've seen this in not just our PSI work, but in our Global Nurses United work, every nurse wants to come onto a shift knowing that they've got the right skills and the right numbers to do the work. And they want to know that's going to be there when they get there, not just, you know, cope with whatever they've got when they get there. So I think between the research and the actual clinicians, it's the only way to go.
Okay, good. Thanks, Judith. I mean, I think that gives us a good direction that our submission should focus more on the ratios. It could be a challenge to get that data in a lot of countries, but at least it gives us.
Oh, look, I'm under no illusion. We've been fighting this for a decade, and we've actually got sister states that, you know, either side of us that have got it. I have no illusion how difficult this will be, but that doesn't stop us from aiming.
But it's part of. Yeah, I mean, I think what we do is, you know, it's an opportunity to put it on the record and get it into, you know, the international debates, even though obviously it's going to be a challenge, but to, you know, bring that as especially in this global moment, as you say, there's evidence, and that evidence will be able to demonstrate that if the world is worried about public health crises, then this is the best way to deal with it. I also noted that there's, you know, this concept of patient to staff time ratio in the Aged Care Royal Commission recommendations. So we can also, because otherwise I don't think there's, similarly, you know, there's only a few countries that have legislated ratios, but I think in terms of aged care or other, you know, outside of the hospital setting, that's
disability services.
Yeah, so we need to do a bit on that as well.
Yep, and to be
okay.
Kate,
so are there any sorry.
I was just going to say, Kate, on the aged care timing ratios, the ANMF has good research on that as well. So we would be able to assist you with that.
Great. Okay, and Trimitra's just said if there are, people can also feel free to type in comments. We're collecting everything. Is there any other comment on this area before I move to the next? Or Carol, did you have any areas here you feel like we need input?
No, I was only kind of
Okay.
thinking, perhaps as we've got participants from 2 countries that have ratified the convention, which is Philippines and Bangladesh, and it might just be interesting to hear how. I mean, I think that the situation with ratios in the Philippines is pretty bad, and I'm just wondering what the kind of reflection from there might be in terms of that. That was kind of just on my mind. But yeah, just
Yep.
yeah,
Okay.
that was my only thought.
Great. We also have Fiji, and Fiji is also ratified. And I think so we have a Philomena from Fiji. So the 3 of them, are there any comments from any of those countries around the language of is from the general survey is the highest level of health attainable, and obviously that is going to require ratios. Oh, sorry, Philomena had to leave. Thomas saying. What about from Philippines or Bangladesh? Any comments? I can't see all of the participants, but I'm pretty sure we'll have somebody from the Philippines.
Jen is here from PS Link.
Jen, do you have any? Maybe her audio is not working well, but we can come back if she would like to comment, but I'll move on at the moment.
Yeah, hi.
Oh, there she is.
Hear me now?
Yes.
Yeah. For the Philippines, I would just like to comment on regarding the term for nurses for community health workers. Because in the Philippines, we have nurses who are licensed, but they are deployed in the community setting. They are in charge of immunization of that particular community. But we also have community health workers who are not licensed and they are not university educated, like the barangay health workers. But they are the first responder in this COVID-19 pandemic. So maybe we can differentiate those 2 because although they are both health workers, but they are not in the same capacity in their work. So that's one of my comment. And for the nurse to population ratios, nurse to population ratios, we usually use this for those nurses deployed in the community, while the nurse to patient ratio are those for the clinical setting.
Okay, that's helpful. So yeah, where you have a community health worker who has outreach responsibilities, that's where you would look at the population. It's more preventative health or primary health, whereas patient ratio, for
because in the Philippines,
clinical settings. Okay.
Because in the Philippines, we have a devolved healthcare setting. So it's not actually centralized, it's devolved. So we have local government units who are in charge of their particular city or municipality. And we have also a national Ministry of Health or Department of Health who are in charge for those hospitals under their care. But also the local government units, they have also other hospitals under their scope. But the main difference is that the salary of our nurses, we have, if I can give an example, we have, when we visited a district hospital in one of the islands in the Philippines, we met 2 nurses. The other one is being compensated by the national government, and the salary was about 26,000 pesos. But the other nurse, who is being paid by the local government unit, is just receiving an amount of 10,000 pesos. So the difference is 16,000 pesos. So that's quite a big difference in the salary. And that's because of the devolution of healthcare in the Philippines.
Right. So there's no national minimum for nurses that's specific for healthcare workers.
For the government, there is.
Right.
Yeah, we have a national standard for government workers. However, because of the devolution, the LGU or the certain city, province, or municipality, they have the autonomy to limit the salary of nurses under their supervision.
Right. Okay. We do have a question somewhere on that as well. One being the difference between public and private wages and conditions, and the other being around the wage setting mechanisms. So we will take some of that information on the Philippines. I think the big variation, that's an important illustration of the huge variation that there can be. Okay, I'll move now on, and then I'll come back to something that you've just said when we get to that question. But the next lot of questions include a number of questions on education and training, which in the survey includes around what sort of national nursing education policy the government has, the regulation of standards and qualifications, and some of this relates obviously to the first area we talked about, so the 3 categories. And then also there's questions around education and training that targets particular public health needs like rural settings, whether education standards and ongoing professional education is developed with unions, as well as the sort of career development and including gender-related career development. So there's a whole set of questions there. We are interested in a couple of areas here, which is, one is a concern we have around the growth in private sector education in nursing, and that has proliferated in a few countries, partly because of the potential for migration, health worker migration. And there's a lot of profiteering in the private sector nursing education. And there's even examples we've heard of, particularly from India, probably from the Philippines, of a qualification in nursing comes with debt and then placement in hospitals and effectively indentured placements or free labour. And we wanted to get some feedback on that. So I know Jibin is here from the United Nurses Association, but this could also be an issue in Philippines or, I don't know, other countries. And then a couple of other messages we wanted in there was around how unions should be involved with nursing schools, and that there's potential for student membership in some unions. And I think that's another way of sort of protecting students against this level of exploitation. So we wanted to provide some input and case studies around that. But yeah, I'm interested in your feedback on whether this is an issue that PSI should try and illustrate more around the dangers of privatised education in nursing and also and care, as well as the case studies on how we could best deal with it and the role of unions. So are there any comments about this area?
Kate, I was waiting for my other mates to hop in here, but I'll just say on the private education, that is creeping in, not in our professional categories, like the registered nurse goes to uni and that's that. And what's left of our TAFE system still looks after the enrolled nurses, but there's a big cost attached to that. In New South Wales, up until the last maybe 5 years, you used to be able to get your education and it didn't cost. Now it costs more to be an enrolled nurse than it does to go to university. And in the aged care sector, we see lots of private, the creeping in of private education around those assistants in nursing and carers that do have a little bit of education. So that's an issue that is not so bad, but we can see it creeping in. On the issue of students, we've just increased our, we call them associate members, and they're basically students that are at university doing their registered nurse bachelors. And we've got about 6,000 on our books of those, and we have difficulty getting into those universities to talk to the students, but where we can create relationships, we sometimes manage to get in either by the front door or the back door. But you're absolutely right in it. We can look at what their education is up to, we can look at how their placements work, and we can also recruit them to be associate members, and then when they graduate, it's much easier to convert them to full-time union members. So that's a program that we just getting to its peak now. It's taken us a while, but it's a good model.
Okay, well, I think we should profile, even if it's just new, or if others have examples, because I think this is a growing area and a danger. And I see Jibin has commented that there is a bond system in India, and particularly in private sector. I don't know, Jibin, if you wanted to comment a bit more on that. It might not be familiar to everybody that there's basically student nurses who are bonded. And I think it's an important area for us to profile. Maybe if there are other countries would like to know about it that also have this problem. Jibin, if you have your
hi,
mic, if not.
Can I?
Great, thank you.
Yeah. So in India, still we have bond system in the private hospitals, wherein the nurse have to serve the hospital for at least 2 years. This is one kind of a direct bond. And apart from this, most of the hospitals do not allow them to leave the job in between, maybe example, after a year, a nurse wants to leave the organization, but the hospital do not allow them to leave. But there won't be a kind of written agreement or written bond. But this is what been followed in many of the corporate hospitals and private institutes. And other places we have seen, suppose you wanted to leave the organization before 2 years, then you have to pay a huge amount as a compensation to the hospital. Then you will be able to leave the organizations. And in another area, if you look at the nursing education in India, nowadays it's moreover government is trying to promote the private sector, private nursing education, wherein the quality is being compromised in a larger scale. The hospitals or the private institutes are not bothered about the quality, what they offer to the nursing students, wherein the patient's life are in stake because we are going to get the unqualified or maybe untrained nurses due to the privatization in India. If you look at the current budget also, the government is not giving any budget allocation to the nursing education. Neither they are coming up with new policies. So this is something which is arising in today's scenario. And also the people who done the private nursing education, they are restricted to get an entry to the public health system. Especially suppose I did my a course from a private institute, and if I wanted to join a government hospitals, I would be given a 50%, 50% reservation, and the 50% reservation goes to the people who have completed their course from the government institution. So this is also happening. And apart from that, now the latest thing has coming as a gender discrimination. That is also coming up now. 90% of the seats are reserved for women employees, and only 10% are reserved for the men. So this is the overall scenario in India right now, wherein all the stakes have been taken by the private institutions and the corporate management, wherein we feel this is not a good sign for the future, because we are going to have a very bad future for the nursing in India. That's it. Thank you.
Thank you. I think this is really important, around particularly the bonded system. It's something we really have to raise. Obviously, India's not a signatory to the convention at the moment, so this is a good opportunity to raise it, because all countries refer, but if not, we should, if they were a signatory, we should bring a complaint. So yeah, we'll note that as part of the focus. I think an important point has been made that we should distinguish between for-profit education, and that's obviously a major concern, because when it's driven by a profit motive, you know, the standards drop, but also this is where the bonded labour comes about, where students incur a debt that can be linked to the provision of the training and to a hospital. And Rob's made the point that there are unions that actually deliver education, and it might be, whether it be, I guess, the initial qualifications or in terms of ongoing professional development and training. So we need to be aware of that. Okay, I know I'm a bit slow, so I'm going to try and speed up a bit. Obviously, this is a big one, some of the working conditions and wages. So this area under this question, I've put, there's quite a few questions that we would want to elaborate on, but they're all grouped in the survey under one area. So wages, they are the questions that are officially there relate to remuneration that attracts and retains. What are the pay setting mechanisms, indexation, whether their equivalency with nurses and other workers, hours of work, work-life balance, and what they call maternity or parental leave. Now, we need to make some decisions around when it's really critical that we show that there's a gender wage gap in this field. And in some countries, there's been a long, successful union campaigns to overcome some of that. In others, there's still a huge disparity between what nurses receive and similar workers. And this question down the bottom around public and private sector that Jen mentioned earlier as well, in the disparity between the wages, and Jibin has just mentioned as well. I mean, even your depending on where your education comes from. The survey allows us to annex as well some of the collective agreements, and it'd be good to get a group of particularly collective agreements that set good standards that are union negotiated as illustrations. But some points here on the gender pay gap, we need to it would be useful to come to some common comparators. We don't have to just have one or two, but we're trying to think of some that might be similar across countries that'll show, whether there's large disparities. And that's a disparity within the health sector as well as one outside of the health sector. And it should be one where there's more men in employment. So some proposals have been in engineering, where say an engineering qualification of a similar length to nursing qualification, and within the health sector, proposed comparison is a physio, but it might be something else. And so we'd like to know from anybody that's run any gender pay gap cases, whether what kind of comparators they've used, as well as get some data on the differences in wages and conditions.
The professional rates case in Australia in the late 80s, early 90s was predicated on comparison with engineers.
Mm-hmm.
And the engineers were the driving rate for the allied health professionals at the time. The Commission here rejected that comparison on the basis that the size of the nursing workforce was big enough to have its own benchmark. So we've got a problem in terms of the comparator argument. The other thing that I would say that we need to address is that the mere existence of collective agreements in Australia, and I don't know about elsewhere, is a barrier to accessing some of the other special case considerations around equal pay, pay parity, and low paid bargaining. So if you've got agreements that scrape the bottom, then to some extent it actually precludes you from getting access to special cases. So I think that there's going to be a need for us to address it in a whole range of ways, Kate, in terms of making sure that we don't exclude the capacity to deal with some of those issues.
Mm-hmm. Okay. Yeah, I mean, look, if engineering has been rejected in some countries, it doesn't mean we can't use it globally. But if there's another example that has been accepted, it might be easier. I think, I know that New Zealand's run, for care workers, has run gender, some successful campaigns. So I don't know if Andrea had any comments on what comparators we could use.
Yeah, we have the equal pay settlement here since a few years. I'm not an expert on it, but I'm happy to check what comparators they used. We also have several other equal pay claims going forward at the moment. One also in our hospitals, the district health boards, but that is for admin and clerical workers in the health context. So I guess that wouldn't be too relevant for this piece of work. But I will definitely check that and get back to you. We have also done, if that might be useful, I can give you access to it, a survey among all of our members in the PSA, which also covers workers in other sectors than health, about their pay. It's called, and we developed an online tool called My Pay. And you can check according to occupation, sector, ethnicity, gender. And it's very insightful when you compare certain professions with each other, and what members do earn. And that might be, might provide some information, some useful information on what workers actually earn compared to other public sectors. And also, I wanted to just talk about just briefly the public-private sector. It's quite interesting that in the healthcare sector, it is reversed. I guess usually we assume that private sector wages are higher than public sector wages. And in New Zealand specifically, our community health workers are employed by private healthcare organizations, and they earn a fraction compared to other healthcare workers employed by our hospitals, the DHB sector, district health boards. So that is, that is quite interesting. And since we have those equal pay claims going, that usually is a problem, because if you're settling an equal pay claim, say for healthcare workers in the public sector, that means that you attract all of the healthcare workers in the private sector and NGOs and, you know, the community sector to those public sectors, depriving the community sector from their healthcare workers. So it's very important to deal with those flow-on effects effectively, and the public-private sector wage gap in terms of healthcare is quite significant in New Zealand and has major implications for, especially for the community setting, which is very important here in New Zealand.
Yeah, I think in a number of countries, once parts of the health system are privatised, which might still be public funding, but it's now a private employer, the way that, you know, obviously that that they're able to extract profit is to push down wages. It might not be across every country or every industry, but it's important, I think, to illustrate it. We have some comments as well in the chat box that wages in public sector are higher than private sector as well. I think in India and in Pakistan, and, you know, particularly where it's unionised, it's going to be higher. And sorry, I've lost, there was another comment which was important. That in India, the variations of pay, I think that's really also important across the states. Sorry, there was a comment from Nepal.
हजुर हजुर नमस्कार, म नेपालीमा भन्छु। यस नमस्कार सबैजनालाई। म अलिकति नेपालको चाहिँ नेपालमा चाहिँ कस
Nirula, we'll just to move to the English channel so that you can hear the translation in the English channel for Nepali. So requesting all the participants who would like to hear in English to move to the English channel in the interpretation icon below. And you should be able to hear the interpretation.
हजुर हस् थ्याङ्क यू। हाम्रो नेपालमा पनि कस्तो छ भन्दाखेरि सरकारी सेवामा कार्यरत नर्सहरूको स्यालेरी चाहिँ अब प्राइभेटमा भन्दा बेसी छ र प्राइभेटमा चाहिँ एकदम मोनोपोली छ। जसले जति मन लाग्यो त्यति नर्सहरूलाई चाहिँ स्यालेरी दिन्छ प्राइभेट सेक्टरमा। यसमा पनि कस्तो छ भन्दाखेरि जस्तो एजुकेसन सेक्टरमा जस्तो नर्सिङ इन्स्टिट्युटहरुमा चाहिँ के छ भन्दाखेरि नर्सिङ इन्स्टिट्युटमा चाहिँ केही हदसम्म राम्रो छ जस्तो स्यालेरीहरुमा हैन, तर हस्पिटल सेटिङमा चाहिँ स्यालेरी एकदमै कम, एकदमै मनपरी रूपले दिने गरिएको छ। र कस्तो छ भन्दाखेरि अलि अगाडि के थियो भने एकदमै भोलुन्टरीली काम लाउने नर्सहरुलाई चाहिँ एकदम शोषण गरिएको थियो। त्यसमा अब हाम्रा संस्थाहरुले, नर्सिङका संस्थाहरुले अनि जस्तो हाम्रो यो हेल्थ प्रोफेसनल अर्गनाइजेसनहरुले चाहिँ अलिकति विरोध गरेको कारणले गर्दाखेरि चाहिँ त्यो ट्रेन्ड चाहिँ कम भएर आएको छ। नर्सहरुलाई भोलुन्टियर काम लगाउने जस्तो हस्पिटलहरुमा भोलुन्टरीली काम लगाउने प्रथा चाहिँ केही हदसम्म कम भएको छ। र अर्को म के भन्न चाहन्छु भने जस्तो अब हाम्रोमा कस्तो छ भन्दाखेरि फर्दर एजुकेसन लिनको लागि जस्तो एउटा नर्सले चाहिँ अब प्रोफिसिएन्सी सर्टिफिकेट लेभलको उले पढ्यो हैन, अनि त्यसपछि उलाई फर्दर ब्याचलर गर्नको लागि, मास्टर्स गर्नको लागि चाहिँ एकदम चुनौती छ। महँगो छ प्राइभेटमा। यता गभर्नमेन्ट सेक्टरमा पढ्नको लागि एकदम लिमिटेड कोटाहरू हुन्छ, लिमिटेड सिटहरू हुन्छ हैन, त्यसले गर्दाखेरि प्राइभेटमा पढ्नुपर्ने हुन्छ। र अब प्राइभेटमा पढ्दा कस्तो सिस्टम छ भन्दाखेरि यहाँ चाहिँ काम गर्दै पढ्दै गर्ने सिस्टम छैन हैन। काम गर्दै पढ्दै गर्ने सिस्टम नभएपछि नर्सलाई चाहिँ फर्दर एजुकेसन लिन एकदमै गाह्रो भइरहेको छ। अब बल्ल बल्ल पाउँछ जब नर्सले हैन। अब त्यो जब पढ्नको लागि उसले फर्दर स्टडी गर्नको लागि चाहिँ उसले त्यो जब छोडेर जानुपर्ने हुन्छ हैन। अब त्यस्तोमा चाहिँ जस्तो अब जुन उसले यस्तो गरे हुन्थ्यो जस्तो लाग्छ हैन। हामीले अब रिकमेन्ड पनि गरिरहेका छौँ हामी नर्सिङ अर्गनाइजेसनहरूको थ्रुबाट चाहिँ, जस्तो उसले जहाँ काम गरिरहेको थियो त्यही प्र्याक्टिकल गरेको पनि उसको चाहिँ काउन्ट होस् भनेर चाहिँ हामीले मागहरू राखिरहेका छौँ। तर त्यो अझै पनि अब पुरा हुन सकेको छैन। नर्सको एकदमै नेपालमा नर्सेसहरू अब अहिले त जब पाउन पनि गाह्रो भएको छ। अराउन्ड 1 लाख नर्सहरू चाहिँ काउन्सिलमा, नेपाल नर्सिङ काउन्सिलमा चाहिँ रजिस्टर भइसकेका छन्। अब सरकारी क्षेत्रमा जम्मा 6 देखि 8 हजारसम्म मात्रै नर्सहरूले चाहिँ काम पाइरहेका छन्। र प्राइभेटमा चाहिँ एकदम मोनोपोली रूपमा हस्पिटलहरूमा चाहिँ एकदमै थोरै वेजेसमा चाहिँ काम लगाइएको छ। नर्सहरू एकदम फ्रस्ट्रेटेड छन् नेपालमा। र अब त्यसको लागि अब युनियनहरूले त्यस्तो अब ट्रेड युनियनमा दर्ता भएको नर्सिङकै एउटा सोलो नर्सिङको अर्गनाइजेसन भनेर ट्रेड युनियनमा एउटा कलेक्टिभ बार्गेनिङ गर्ने हिसाबले चाहिँ त्यसरी दर्ता भएको खै मलाई अहिलेसम्म याद छैन। त्यस्तो नर्सेसहरूको चाहिँ युनियन जुन चाहिँ ट्रेड युनियन दर्ता भएको छैन। त्यसले गर्दाखेरि चाहिँ अब हामीले आफ्नो हक अधिकारको लागि चाहिँ धेरै लड्न पाइएको छैन। हस्, धन्यवाद।
Thank you. That was very useful on a range of issues. Some that I think we might need, that we haven't sort of scanned ourselves, which is the professional development not accessible, and also the importance of unions that don't exist in some countries.
जहाँ उसले पहिले काम गरिरहेको थियो नि, फर्दर एजुकेसन गर्दाखेरिको त्यो प्र्याक्टिकल चाहिँ काउन्ट भइदिए हुन्थ्यो जस्तो लाग्छ के हाम्रो विचारमा चाहिँ। र त्यसको लागि हामी अब पहल पनि गर्दैछौँ।
I'm sorry for the interpreters.
Okay, thank you. That's really helpful. I'm going to move on now. There are a range of issues around wages and conditions that we'll need to do more on, but just to give a sense of the other areas that we're going to be focused on and the key messages.
Ramji also has his hand up from the panel.
Can I just, okay, sorry. I don't see hands up, so you'll have to interrupt if there's a hand up. Go ahead.
Ramji, please go ahead. You have to unmute, Ramji. Okay. Maybe we can take his intervention later then. Please go ahead, Kit.
Okay. Yep. So this area on excessive working hours, the one area that is in the recommendation is around the potential to reduce hours because of particular working conditions. And that would, I think, have been relevant to the conditions some nurses were working in during COVID, particularly with the heavy PPE. And we want to, but we also know that a range of affiliates have reported back about the excessive workload, the extended hours, the back-to-back shifts. Many places, nurses have been required to stay on site and do continual shifts without leave. So this is an area that we're keen to get further information on. Also, whether in emergency situations where there are requirements to do more, extended shifts or to vary the agreed conditions, whether unions were involved in making those exemptions, and that would obviously be, COVID would provide an example of that. So some of the key messages, we also wanted to elaborate on there's a whole body of research that shows excessive work hours and excessive pressure for nursing and healthcare workers have negative public health outcomes. So we're looking for research. We have some, but also if you would like to contribute. And that the other sorts of conditions where shorter shifts might be required. Yeah, and these are some of the clear areas that we think would fit under this one.
Adil had requested to speak, and then also Jibin has put his hand up.
Okay, go ahead.
Maybe Adil, you could start. I don't think we can hear Adil.
We don't hear you, sorry, but I don't think he's on mute.
Adil, you are not showing on mute, but we cannot hear you. We can see you. There is no sound at all.
Okay, maybe we can go to Jibin and then come back if they can fix their sound problem.
Yes, Jibin here. So I was thinking about the payment structure in India, wherein if you look at the private area, what they pay to a nurse is basically less than $100 a month. That is a pay scale to the nurses in here, what we are getting to the private area. Whereas in public health system, yes, of course, they have a good pay scale. But the problem there is now the government is trying to promote the contract employment, wherein the nurses will be appointed by a third party, and there will be a contractor who handles the pay scale of nurses. That is also a new way of exploitation. And if you look at the overall pay scale in the Indian industry, it is like less than $100, as I said. But now there are unions who are trying to improve the working conditions and the pay scale for the nurses. We've been trying since last couple of years, and there is a clear recommendation from the Supreme Court of India stating that the nurse should get a minimum wages of at least 20,000 Indian rupees. So, but still none of the hospitals or the states are implemented this law. But we are trying very hard with other unions to implement this. Hopefully we'll get that. And if you look at the working hours for the nurses, it's like 12 hours. Sometimes in majority of the hospitals are following 12 hours work time. And in COVID, now the situations are increased, and nurses are doing a shift timing of more than 12 hours with PPE kits. This is a bad scenario which is going through right now. And if you look at the other benefits, for example, maternity benefit, because majority of our workforce are women, so they don't get the maternity benefits, no maternity leave, no medical benefits, which means if a nurse falls sick, they don't get covered by any insurance. They don't get any health coverage by the government or by the hospitals. And if you look at other benefits other than their pay scales, the nurses are not getting comparatively with other workforce in India. So that's it.
Okay, that's interesting. When you said that they're using a contracted employer, like an agency, is that in the public system or private or both?
See, it was already there in the private sector, but now the government is putting the same into public health system even. If you look at every state in India, now they're coming up with contract laborers in the public hospitals.
Right. Okay. Well, I think this is an area around the job security that we need to really emphasise. The increased reliance on outsourced work, insecure work, agency work. Yeah, I think although the survey itself didn't have a specific question, we've decided as PSI that we're going to emphasise this area of job security and outsourcing. But also the point that you made, Jibin, I think, on the fact that there's a decision, a Supreme Court decision that's not been implemented, we should also include that, because I think that the gap between formal governments sometimes submit the formal standards in these surveys. That's often what they're submitting is, we have this law and that law, and but the reality is often very different. So that'll be an important area for us to illustrate, and also to demonstrate the importance of unions. Yeah, so if there's other kind of areas of insecure work that we need to illustrate, this will be really important. And I think this will lend itself to more campaigning, trying to get the ILO to recognise the broader problem, of course, which they have, but also the reason that we wouldn't want to see, if there's a new convention or an updated convention or updated recommendation, why that provision needs to be removed that seems to favour temporary work. And then still within this group of questions, some questions on occupational health and safety and the specifics for within healthcare, and Carol gave a good summary of the issues at the beginning around how significant the occupational health and safety risks are. But we also, we need to collect as much information as we can about this. And some of it is occupational diseases, and when, how do unions have a role in recognition of occupational disease? Is the sick leave for nurses adequate given, the risks they face? And that should be higher in than other workers. We also want to include issues around mental health. And we know that COVID has provided an illustration of that, the stress levels of work and the impact that has on workers. I know that, the example of the UNA in India, where they started the union specifically because of the very serious mental health impact and suicide of nurses. And also we see it as a potential opportunity to highlight the importance of the new Convention on Violence and Harassment in the World of Work, and how those provisions could be important for workers, for nurses and healthcare workers. Including provisions like domestic violence leave. So if any unions have already negotiated those provisions, that would be useful. I know that the recent New Zealand example of how workers now have access to miscarried leave for miscarriages, that could also be a good illustration of what might be needed in a setting like nursing and care.
Kate, we have two hands that were up from
okay.
before. One is Adil and also Jamu.
So
maybe we could try Adil first.
Yep.
Okay, can I speak?
Go ahead.
Hello. Can I speak?
Who is that? It's Jamu,
Hello?
is it?
Yeah.
Yes, go ahead.
Good afternoon. Good afternoon. Yeah, in my city now the second wave is worsened the situation. Therefore, the health staff is overburdened. None of them could join today. Every passing day, the situation is getting worsened. So there is a big pressure on these urban primary health centers, which are, come up under National Urban Health Mission of the Government of India, which has launched. The point which I want to draw here is, at least in urban local bodies, this structure of urban primary health centers managed by National Health Mission authorities, it is nothing but contractual health system. The staff is called as contractual staff. Here, the mechanism is you will not find a private contractor, or there is no private entity where the corporation has to enter into an agreement as such. But the whole mechanism is such that a NGO has to be formed to receive funds, and then and there is it is well defined who will be the office bearers of that NGO. It is primarily all the officers of a public body, but particularly in the urban centers, it will be the officers of urban local body. They will be the office bearers of that NGO, which will be registered in one of the Indian laws, where generally the NGOs are being registered. So the money flow comes through that NGO, and these health workers who are part of this primary health centers are basically called contractual workers, because the local body and a body which is being formed by the officials registered as an NGO, both will sign some agreement. So legal entity of these health workers are like that, they are the employees of that NGO. So this is and both are public, but the basic nature is contractual worker. So this is a new kind of contractual system in my country. The government of India has adopted, and here no labor laws are being implemented. They don't receive minimum wages, they receive honorariums. Recently, the government of India revised their honorarium, and which they brought at par with that of the minimum wages under Minimum Wages Act. But the question here is, at one hand, these health workers are called as a contractual workers. On the other hand, they are not recognized as workers. And second, the hospitals managed by the urban local bodies and the staff in the urban local bodies, the salaries are, there is a huge difference between the health workers drawing the salary who are permanent health workers of the local body, and the staff which is working in urban primary health centers. Huge difference, about 3/4 difference is there. So it's a peculiar kind of arrangement where these health workers today who are volunteered or shouldered the lion's responsibility of COVID in the urban centers and getting 1/4 of the salaries or the honorarium to their counterpart who are permanent health staff, including the doctors, ANMs, JNMs, technicians, pharmacists, attendant, whatnot. So this is one area, I think, the mechanism which adopted by the government of India is to be questioned.
Yeah, okay. That is, I mean, the lengths that some some governments go to create insecure work, is unprecedented. So setting up an NGO just so that you can circumvent the labour standards would be an important case study. And I think also, as you said, whilst for the gender pay gap, we're looking for a comparison between similar work, we should also look at the comparison within health whilst, that it should never warrant that one health worker is paid 3-4 times the amount of another health worker, even if their qualifications are different. So these should all be part of the documentation. I can also see a couple of other comments here about, so we do have case studies on domestic violence leave that we can include. Yeah, so these are important. I'll move on, but you can see here the other point was about a hierarchical work environment. So I think the less power nurses have, the more sort of stress, the more risky the occupational health and safety is, and that. So in different countries, the nurses have, the hierarchy is always going to be with doctors, but the power of nurses can be a lot more significant, particularly where the union is powerful. I think we should be making that point in this submission, that a key way to overcome the hierarchical problems, the occupational health and safety risks, is through unionising.
Kate, you have Adil's hand up, and we are already a bit over time. So I don't know if you want to give people an idea of how much we would like to extend.
Yeah, so Adil, if you're able to speak now, we'll try, and we might need to extend. We're already over time, you're right. So if everybody's okay for another 15 minutes, I'll try and really rush through the next points. But Adil, would you like to go ahead if you've fixed your audio?
Hello, can you hear me?
Yes, yes, we can hear you now.
Yeah, good afternoon, everyone. I'm Adil Sharif. I'm General Secretary of Indian National Municipal and Local Bodies Workers Federation. I represent municipal and health workers in India. I base in Telangana, Hyderabad. Along with me, I'm having ASHA workers and Anganwadi workers. And we would like to compliment the Public Services International team for organizing this webinar meeting. The ASHA workers, which is called Accelerated Social Health Activist, these are the term used to victimize or threaten the workers. These workers do not been considered as workers and denied the rights which have been guaranteed under the Contract Labor and Regulation Act 1970. So these are the scheme workers which are working from morning till evening, which are serving the community, which are serving the health. And we have observed that recently COVID situation, these workers are the first to visit the quarantine person and have a social services in the community. And these are the COVID-19 warriors, which have served the community in the larger way without being provided the basic social protection of mask, hand gloves, sanitizer by the government. So these are, we were organizing these workers to form a trade union to come under the purview of trade unions, but so many workers have been terminated by their employer for joining the trade union activities. So anyhow, we have mobilized this section of workers, and we are having regular meetings with them, and we are demanding for decent work, decent pay. There are a lot of issues concerning these workers, that unpaid wages. Some of the workers who have worked in the pandemic situation during the lockdown have not been received their worked wages after a gap of 6 months. After 6 months, after the involvement of the union, they have got their wages being worked in the month of March, April, and June. And their issues are low wages. Compared to other contract workers, their wages are very less. Now they are getting around 8,000 rupees to 10,000 rupees. And I want to share the example that in the municipal sector in contract labor, the sweeping workers get the remuneration of 17,000 rupees, whereas the workers who serve the community in the health sector, they get only 8,000 rupees. This is a discrimination. And overtime work is there, and there is no sick leave or maternity leave, no ESI, no EPF, and no job security, and these are precarious employment. And more than these workers have not been considered as the workers, so that we can demand in the labor department or the concerned authority. They denied that these are not the workers, and they are using this COVID and pandemic situation to harass the workers, that whoever does not work or whoever join the unions, they will be removed from their services. So anyhow, last year we have conducted the workplace campaign, and we have united the ASHA and Anganwadi workers, and we have protested also, and we have published in the media our news, the demands of the ASHA and Anganwadi workers to revise the wages of these workers. So we are having a success story also, that because of the support of the Public Services International and because of the efforts of the ASHA and Anganwadi workers, because of our protest, the Chief Minister in the recent assembly, the Chief Minister is forced to take the name of these ASHA and Anganwadi workers in the assembly, and they have recognized the services of ASHA and Anganwadi workers, what they have served in the COVID-19 situation, and the Chief Minister is forced to enhance the remuneration of these ASHA and Anganwadi workers to 3,000 rupees from 10,000. Now they will be getting 13,000 after so many agitation protests by the union and support by the Public Services International. And though we have not received any GO for enhancement of this order, but the Chief Minister himself has praised in the Assembly of Telangana that these workers' services should be recognized and the remuneration should be increased to these workers. And I would like to conclude here, and I would like to give the mic to my colleague, from the community health worker. She wants to share something. Thank you very much.
Hello, sir. Hi. Andariki namaste.
Namaste, go ahead.
Sir, వినపడుతుందా సార్ మీకు? సార్ వినపడుతుందా? Hello? Hello?
We can hear you. Just let me. Yes, I can hear you. Go ahead.
సరే సార్, ఓకే సార్, థ్యాంక్ యూ. సార్, మేము హైదరాబాద్ తెలంగాణ నుంచి మాట్లాడుతున్నాము. మా యూనియన్ INTUC ఆదిల్ షరీఫ్ సార్. సార్, నేను కేఆర్గూడ టు అంగన్వాడీ టీచర్ను. కేఆర్గూడ అంగన్వాడీ టీచర్. మా ఏరియా కిషన్ బాగ్ సార్. మేము 250 ఫ్యామిలీస్ ఇండ్ల నుండి సర్వే చేస్తాము 1500 మందికి. ప్రెగ్నెంట్ లాక్టేటింగ్ మదర్స్ 0 to 6 years, ఆశా వర్కరు, అంగన్వాడీ టీచరు.
I'm not getting any translation.
హౌస్ విజిట్లు చేస్తాం సార్. మళ్ళీ MTF, weight, grade, immunization, వీళ్ళందరికీ గ్రోత్ మానిటరింగ్.
Sorry, we're not getting the interpreter.
Madam,
is the interpreter helping? Can anybody hear the translation?
వినబడతలేదా సార్? మేడం వినబడతలేదా?
Sorry. Okay, so Brother Adil will do it next, will you?
Hindi ji.
Can you do Hindi for us? We have, if you could speak Hindi.
Hello, can you hear me, ma'am?
Yes, I can
Hello?
hear you now. Yes, go ahead.
Can you hear me, ma'am?
Yes, I can hear you.
Ma'am, I'm speaking from Hyderabad, and my area name is Kearguda 1, Kishanbag. I'm working as an Anganwadi teacher. So since 12 or 13 years, I'm working in this area. So we have so many issues. Means हम लोग अब तक सर्वे पूरा सर्वे एरिया में जितने भी हाउसेस है 300 तक सर्वे करे, उनमें से पूरे लैक्टेटिंग मदर्स, प्रेग्नेंट्स, ये लोग को सारे लोगों को सर्विसेज देते, हर चीज प्रोवाइड करते। इवन कोविड में भी हम लोग घर घर जाकर वो लोग को राशन दिए, सारी चीजें, सारे फैसिलिटीज वो लोग को दिए, क्योंकि जो नहीं आ सकते, जैसा कि लैक्टेटिंग मदर्स है, वो लोग घर से नहीं निकल सकते, तो वो लोग को भी हम लोग सारी चीजें प्रोवाइड करें। कोविड पेशेंट्स को भी, और जितने भी कोविड पेशेंट्स थे वो लोग आशा वर्कर्स के साथ जाके वो लोग को घर बताए, हम लोग वो लोग को वहां से निकालना, करना, लेके जाना, एडमिट करना, सारी चीजें हम लोग किए। लेकिन इतना करने के बावजूद भी हम लोग को कोई देख रहा नहीं है, यानी हम लोग क्या कर रहे हैं, क्या नहीं कर रहे हैं, और सोशल प्रोटेक्शन नहीं है हम लोग को। इवन अगर हम मर भी गए तो हम लोग को देखने के लिए कोई नहीं है, यानी इवन इतने साल करने के बावजूद हम लोग को कोई बेनिफिट्स नहीं है, हेल्थ कार्ड नहीं है हम लोग को, ESI PF भी नहीं है, इवन हम लोग वर्कर्स है बोल के भी हम लोग को कोई देख नहीं रहा है कि इतना काम, हर चीज हम लोग को BLOs की ड्यूटी, हर ड्यूटी हम लोग से करवाते हैं। हम लोग घरे घर जाके सबको स्लिप्स देते हैं, हर चीज करते हैं। हम लोग को इवन ID कार्ड्स भी प्रोवाइड नहीं है, हम लोग को ESI कार्ड्स भी नहीं है। तो हम लोग ये चाह रहे हैं कि हम लोग ये सारे यूनियंस एक होके हम लोग को हेल्प करिए। हम लोग का एक प्लेटफॉर्म चाहिए, हम लोग को एक प्लेटफॉर्म बनाने के लिए हम लोग ये कर रहे हैं, पूरा ये चीज ऑर्गेनाइज कर रहे हैं। थैंक यू।
We would like
Thank
to
you.
conclude here. Thank you.
Great. Thank you for the intervention, both speakers, and we really appreciate the effort you've made to all the webinar. Congratulations on the great news that you had for us, that you've got improved wages by a large percentage. That's really great news. And we will make sure that this survey highlights the struggle of the ASHES and the community health workers and Anganwadi. So, yeah, we will ensure that the information you've provided is part of brought to the international attention. Comrades, I'm really sorry that we're taking a little bit longer, but I do think it's important to hear from, we've got such a huge region, the Asia Pacific, and such different circumstances for all workers. And so there's a, obvious need to hear from everybody where we can. I'm going to try and rush through some of the next parts of this survey. But as I said earlier, we will come back to you and look at each country's situation in more detail. But the situation for ASHES and community health workers in relation to social protection is particularly a good illustration, and we have that here, how community health workers are excluded from social security. In some countries, migrant workers are also excluded. So an important part of this question will be who has access to social protection and who does not, but also what other gaps are there in social protection, whether it's adequate, particularly for women who may, take breaks and then have not adequate pension, etc. There's a set of questions specifically on migration. For PSI, we'd like to focus in here a bit on the illustration of examples where unions have played a better role with migrant workers, either unionising migrant workers in your country. So if in some nurses unions have specific organising strategies for groups of migrant workers, and in that way ensuring that they are not exploited when they come to the country. That's one example we can provide of why it's so important to allow and to promote unions in the sector. Also the bilateral agreements, and this is where the Philippines could be a good example of where unions have played a role in trying to protect the nurses who've migrated in that case to Germany. Yeah, but you may have other other information for us, either for the global submission or for national, on issues to do with migration. At the same time, we need to emphasise that we are not trying to, exploit the situation, and that we want to address the drivers, that migration does drain the national health systems, and that should not be an answer to the global health shortage in nurses and health workers, and that there needs to be other responses from government, particularly investment in proper public education and decent wages and conditions that will attract and retain staff. Obviously, social dialogue. The big question for us will be, in some countries, there is large restrictions on unionising in the health sector. In some countries, that's only on the public health system. So Indonesia is an example. I think we've got comrades from Indonesia, where only the private system can unionise. In some countries, there are restrictions on the right to strike, and I think we need to make our position clear on the right to strike, that whilst health workers don't take it lightly, it should not be a right that's eliminated from nurses and health workers. And we will I think one area would be to provide illustrations of why the right to strike has been important. For example, in cases of where there's large both occupational health risks and public health risks, the COVID has provided some illustrations of that, of unions who took strike action because they were sure that the system was inadequate to deal with COVID until it was improved. We also have the obvious example here of health workers in Myanmar who have said that they needed to strike for not their wages and conditions, but for the broader public good. And so we would also be illustrating those. So there's a lot of examples of social dialogue that are not only obviously about the right to strike, but also about how employers, governments and other employers interact with unions, what voice do workers have in public health policy or in decisions that relate to their work. And we'll be wanting to illustrate those, as well as what dispute mechanisms do countries have and whether they're effective or not. So that's a large area of work that we will need to come back to you on, because there's obviously big variations and we're running out of time, but please give some thought about how we can approach that part of the question. And then finally, really, is the set of questions that are key around what are the challenges in the current ILO standards and how they should be addressed. Now, we really will be, around the world getting input and hearing from affiliates about how much of a priority this should be made. We should make this over the next few years, because it will take years. If affiliates feel like an international instrument that's updated would be useful for them, we will campaign around changing this instrument. But if instead affiliates feel that it's difficult, to get that, and instead we should push for further ratification, now is the time to do it. Governments obviously are going to be making different gestures towards health workers, and one of them we should be saying is, if you do respect health workers, you should ratify this convention. But at the same time, we've highlighted a couple of areas we're unhappy about in there. So this is really important to hear from everybody. I know, it can be, I think we need to give further discussion probably at our sub-regional meetings and then at our regional executive, as well as globally. We need to consider this at our executive board, but I think it's really important to know how much affiliates want to put in. We can run a campaign, but we don't have power alone. We could only have any impact if affiliates feel that's important to them. In any case, we should illustrate the fact that it's, that the convention has not been ratified by many countries. Even if we think the long term we want a new one, it can take up to a decade. So we should be pushing for ratification in the interim. It gives us some power at least to make complaints when governments contravene, and also to participate in more regular review processes. This is a 44-year review, so rather than the regular review if they had ratified. Okay, so I think that's the end of our coverage. I know it's a lot to deal with. If anybody would like to make any final comments before we close, now is the time.
There is a hand up from Zulkarnain Kaskeshi.
Go ahead, please. No, sorry, I can't see the hand. Susanna, can you tell me who it was again?
Zulfikar.
Zulfikar. Sorry.
It's Zulkarnain who has a hand up.
But yes,
जी मैं हलीमा लगारी बात कर रही हूँ. असल में मेरा जो नेट है वो डिस्कनेक्ट हो गया है. तो जब आशा वर्कर की बात हो रही थी उस टाइम ही वो नेट डिस्कनेक्ट हो गया था. तो मैं जुल्करनैन के जो है नंबर से बात कर रही हूँ. और हम पाकिस्तान में भी जो लेडी हेल्थ वर्कर है, भारत में जैसे आशा वर्कर है, पाकिस्तान में लेडी हेल्थ वर्कर है, इनकी तादाद तकरीबन 1,24,000 के करीब है. और हम लोग भी जैसे रिस्क पे, हमें भी कोई भी जो है सिक्योरिटी फराम नहीं की गई है. कोविड में हम काम करते हैं जिस तरह आशा वर्कर काम करती है. हमारा काम भी बेसिकली जो है हेल्थ केयर प्रोवाइड करना है, प्राइमरी हेल्थ पे कर रहे हैं और खानदानी मनसूबाबंदी यानी कि फैमिली प्लानिंग में काम कर रहे हैं. तो हमें भी कोई जॉब सिक्योरिटी नहीं है. बड़ी स्ट्रगल करके हमने बड़ी जिदोजहद करके हमने अपनी जो है वो प्रोग्राम को रेगुलर करवाया है. इस टाइम हम जो है रेगुलर मुलाजिम है, लेकिन जो रेगुलर मुलाजिमों को जो बेनिफिट मिलते हैं, पेंशन मिलती है, वो कोई चीज भी हमें नहीं दी जा रही है, ना हमें सीनियरिटी दी जा रही है. हम 1994 से काम कर रहे हैं. और कोविड में तो हमें बड़ा ही मसला है, क्योंकि ये मसला है कि घरों में जाते हैं और बगैर सिक्योरिटी के जाते हैं. ना हमें पीपी किट दिए जा रहे हैं, ना हमें मास्क, ना सैनिटाइजर, कोई भी ऐसी चीज हमें नहीं दी जा रही है. हम फ्रंट लाइन वर्कर हैं और फ्रंट लाइन पे काम कर रहे हैं.
बात कीजिए.
जी हाँ, तो यही बता रहे हैं कि हालात मुख्तलिफ नहीं है. पाकिस्तान में भी जो लेडी हेल्थ वर्कर की जिंदगियां हैं वो रिस्क पे लगी हुई हैं. यहाँ भी अगर कोई मर जाए तो कोई पूछने वाला नहीं है. अभी तो कोविड है, उससे पहले पोलियो में काफी हमारी लेडी हेल्थ वर्कर हैं जो शहीद हुई हैं, उन्होंने अपनी जानें गंवाई हैं. और उनकी जो है कोई पोलियो में भी सिक्योरिटी नहीं मिलती है, लेकिन इन मुश्किल हालात में भी हम लोग जो है वो काम कर रहे हैं और इसके साथ साथ अपने हकूक के हासिलात के लिए जिदोजहद भी कर रहे हैं. हम पीएसआई के थैंक्सफुल हैं कि पीएसआई के प्लेटफार्म पे हमें जो है मुत्तहद होने का मौका मिला और काफी हमारे मसले मसाइल जो हैं वो पीएसआई की मदद से हमने अपने हल करवाए. और सबसे बड़ा हमारा मसला जो यूनियन हमारी रजिस्टर्ड नहीं हो रही थी, वो भी पीएसआई की मदद से हमारी यूनियन रजिस्टर हुई है.
Yes, go ahead. बात कीजिए.
Thank you, sister. It's really important to hear from the lady health workers, community health workers, and ASHA, and Zulfikar, Sister Banani, Sister Jenny. Together we'll make sure that
अगर किसी को पाकिस्तान की लेडी हेल्थ वर्कर के लिए मजीद जानने के लिए कोई क्वेश्चन करना हो तो मैं हाजिर हूँ.
Thank you. शुक्रिया आपका.
Excellent. Thank you, sister. We will make sure that we speak more to you about putting in a submission to the ILO specifically about the conditions for lady health workers, ASHAs, community health workers. Thank you. Was there
जी
another
बिल्कुल,
hand?
मेहरबानी, आपका भी शुक्रिया।
Jibin also has his hand up.
Go ahead,
Yes. Hi. So finally, I take this opportunity to thank Public Services International for inviting us for this such a wonderful program, because this is so informative. I think we will have a lot of things to add in it. And I also recommend ILO to have more interaction with nursing unions, especially from India, because from India, there are a lot of nurses move around the globe. I mean, I think we would be the one of the country sends highest number of nursing personnel to the globe. So we need to have the highest quality from the profession even. So looking at current scenario in India, I think we need to have more interventions with the government, and also should have a more debate with the government so that we get good quality professionals, and we can also have a better working condition for the nursing professional. So that's what we demand, and we thanks ILO for the same, and hopefully in the future we can extend our support to ILO, and also we can expect your support in gathering all the same. Thank you.
Thanks, Jibin. Also, the research that's been done in India with UNA and the WHO, PSI, I think that will be an important piece of work that we can use for this review. Okay, if there are no further hands up, I'd like to thank you all for coming and apologise that I wasn't able to keep on time, but I'm sure you can all see how big this work is and why it's so important. Really look forward to working with you all throughout the process, which, as I said, will be a number of, and probably take considerable time up over the coming years. And you'll be hearing from colleagues, from sub-regional secretaries. Susanna is helping at the regional level, and obviously at the head office with Baba. We have also employed a new colleague starting next week who will help us to fill some gaps in doing this research. So we'll be able to get back to you. And Carol will be leading the overall, or helping to put together the overall review, and maybe in contact with some of you from the notes we've taken today if we need to follow up on specific references that you've mentioned. Please send us any material that you think is relevant right now, and let us know, yeah, what if you have any further needs to support the processes. If there's no further questions or comments, I think, yeah, I can let you all go, as it's been a long meeting. And again, thanks, comrades. Good night.
Thanks, everyone. Thanks a lot to